Welcome to Street Medics Dallas Training. I'm Gear, the Operations Manager for Street Medics Dallas, and today we'll be talking about identifying and treating common protest injuries. Please note that the presentation attached will contain graphic images of injuries, so discretion is advised. There are a variety of injuries any healthcare professional can run into, but there are going to be a few that we're going to focus on here because we are covering protests. I know a lot of you have watched the news. I know that you've seen a lot has gone on. But today we're going to try and focus on 4 specific things that we can treat in the field as best as we can, and identifying when we need to move to a higher level of care, calling EMS or driving them to a hospital or whatever your protocol in your area is. For today, though, we're going to cover skin trauma, rubber bullets, trampling injuries, and how to react to tear gas. But before we get started, there's a saying I always push on the medics in Dallas, and that's, a dead medic saves no one. What this means is don't go out and be reckless. If you fall, that makes you another patient. If you die, that makes you another statistic. And it means that you're not helping anyone. It means that no one is being saved by you. So we're going to start with an assessment. So we're going to start by talking about scene safety. Scene safety is a term that refers to the medic's ability to observe what's going on around them and decide whether or not it's safe to proceed. A patient may fall, but you don't want to rush into the middle of traffic to try and grab them because now you're putting not just their life in danger, but your own as well. You have to check and make sure the scene is safe. Look around. Are there bullets flying? Are there cars running through? Are there horses trampling the people? You have to wear your personal protective equipment. I don't care what's going on. I know you're in a rush, but a good medic slows down and takes their time. Put on your gloves. Make sure, especially now, you're wearing a mask, face shield. Keep barrier devices in place so that you don't accidentally give yourself something that you didn't walk in with. And to reiterate, it's tempting to rush in. I get it. I've been a medical professional for 15 years. I know that when everything goes down, when the fecal matter hits the oscillating device, you want to rush in and save as many people as possible, but you are going to make yourself a target and you're going to make yourself a casualty. That's one less medic and one more patient, and in a lot of these really high-stakes situations, we can't afford that. So remember that a dead medic saves no one. Now that we've got the basic safety stuff out of the way, let's talk about skin trauma. There are a few different types, and there's a few different treatments for each. A lot of them depend on the severity of what you come across. But we're going to give some basic information here. We're going to start with a laceration. A laceration is a fancy way of referring to a cut. It can be caused by blunt force trauma. It can be caused by sharp force trauma. There's a lot of different ways you can get these kinds of cuts. It can be small. They can be big. The larger ones may require stitches, but best thing you can do in the field is to clean the wound using distilled water or normal saline if you have it. And then you want to bandage that wound. If you have alcohol or you have Neosporin, you can use it as well. But going off of having a very basic, simple kit, you want to clean the wound and then you want to bandage it. You want to make sure you apply enough pressure that the wound stops bleeding, but you don't want to apply so much the patient can't feel their fingers or toes anymore. An abrasion is a fancy way of referring to a scrape. It can bleed profusely or it can ooze blood slowly. It's pretty much the same thing. You want to clean it with normal saline or distilled water and then cover it with gauze and tape or bandage it or whatever else you have to help stop the bleeding. You probably won't need as much pressure to take care of this because they don't tend to bleed as badly as a laceration can, but use your best judgment when you're in the field. Puncture is pretty straightforward, usually referred to as a stab wound. Punctures can be of varying depth and be from different things. Punctures can include wounds from rubber bullets, they can include stab wounds, they can include stepping on a nail. These tend to go deep enough that they can cause infection, so you want to clean the wound and cover it with gauze and tape, or use some kind of wrap. Deep punctures are going to require ER intervention. Now, an important thing to know about punctures: if the object is still in the person, I know that your first reaction may be that you want to remove it, but you must not do that. Removing the item that has punctured them can cause certain complications. For instance, if someone's been stabbed, sometimes that knife is the only thing stopping them from bleeding out. And I know it's immediate instinct, get the foreign object out. But what you actually want to do is wrap and stabilize whatever object is puncturing them, and so it doesn't move. If the puncture wound is deep enough, they probably need to go to an ER because they need a specialist to get it out of them without causing more damage or letting them bleed out. That's not something we can typically do in the field. The final injury we're going to cover is probably the most squickish for most people. It's called an avulsion. An avulsion is when skin is pulled away from the muscle and bone, creating a flap. This is sometimes also called a degloving injury. That's when the skin is peeled back off of the hand, for instance, and basically comes off like a glove. Now, degloving injury can happen anywhere on the body, but it's named because it's similar to like taking off a glove. If you see this, you want to clean the wound and apply pressure that, if you can, with a clean gauze. Elevate the wound, wrap it, and for the most part, avulsions require surgical intervention, so you're going to need to send them to the hospital in order for them to not end up losing a lot more blood or getting a really bad infection or both. Let's talk about tourniquets for a second. Back in the day, long time ago, like 15 years ago when I started doing this, tourniquets were considered the absolute last resort when it came to bleeding control. These days, we're a bit more liberal with their usage. They're designed to stop bleeding in pretty extreme situations where direct pressure isn't working. So if you're applying pressure and elevating a wound and that blood just is not stopping, then it's time to use a tourniquet. To use a tourniquet, what you're going to do is apply as much pressure as you can to the artery, which is most likely ruptured if you're having to use a tourniquet, and then tie the tourniquet and twist it. And then once the windlass is fully twisted, you'll stabilize it. Tourniquets like the ones you see on the screen here, the combat action tourniquet, have all that stuff built in. There are ways to build tourniquets out of stuff that you have lying around. A shirt and a tree branch would work, technically. But for the purposes of this, I'm just going to go so far as to say they're used for extreme bleeding. Put pressure on the artery and wrap the tourniquet on. This is an extremely painful procedure. The patient's not going to like it. But you have to apply the proper amount of pressure no matter how much screaming happens. You also need to mark the time it was applied. Some tourniquets will allow you to do that. They have a spot where you can mark the time. But an old army trick is you use your gloved finger, dip it in the patient's blood, write the letter T on their forehead followed by the time, preferably military time so there's no mix-ups. That way, the doctors know how long the tourniquet's been on, and they can take appropriate measures from there. Alright, let's talk about rubber bullets and beanbag rounds. Federal agents and local police have been using them around the country lately, and they have generated a lot of buzz because despite being called non-lethal, they actually can be quite lethal. A British study indicated that 15% of targets who are hit by these things suffer permanent disabilities, and 3% of wounds are fatal. That's a lot. And it's going to be up to us to deal with the injuries that happen as a result of the use of these items. Now, we've covered some of these injuries in the previous slides. They can cause punctures, they can cause lacerations, but let's go over a few other things they can do and how we can take care of them. Skull fractures are a pretty severe problem, and they're treated a little bit differently than you would other fractures. You don't want to apply pressure to the head whenever there's a fracture present. Now, our more advanced medics might remember something called DCAP BTLS. It's a mnemonic we're designed to remember how to search for specific wounds on the body. The C in DCAP is crepitus. Crepitus is a crackling feeling on the skull. It's indicative of fractures and crumbling bones. Now, if there is a head wound like this, you do not want to apply pressure the way you normally would because head wounds are a bit different. If there's a fracture there, you could be increasing the intracranial pressure, or the ICP, of the patient, and that can lead to fatalities. So with skull fractures, you want to lightly wrap the head wounds without applying pressure, and then you want to stabilize the patient's neck. And we're going to go over that in a couple of slides, so remember that because we're coming back to it. Eye injuries, another squickish thing for a lot of people. you have to treat them a little bit differently as well. Much like with other impalements, if there is something sticking out of the eye, you have to stabilize it. But in this case, it's important to remember that when you bandage one eye, you must bandage the other. When you move one eye, both eyes move together. So if you leave one eye uncovered, the patient's going to instinctively look around, and by doing so, they're moving both eyes, including the one that's injured, and doing even more damage. Don't remove anything lodged in the eye, but stabilize it like you would before. Bandage both eyes, and then try to get that patient to the ER as soon as possible. If there are broken bones in other areas, specifically extremities, then splinting needs to happen. Now, typically, this is something I would say you want to leave to EMTs, especially since a lot of our street medics may have the supplies necessary to properly splint. But you can also do what's called a body splint or a self-splint. This is, for example, when a patient's leg is broken, you tie the two legs together to create stabilization. Again, this is something you probably want to leave to your EMTs if at all possible, because doing it incorrectly could cause more severe problems, but the option is there in an absolute emergency. Crush injuries. Now, in protest, crush injuries are generally caused by trampling. It can happen from crowds, it can happen from animals. One of the images on the earlier slide in this presentation showed a woman being crushed by a horse. Now, these injuries can be very severe because they can cover a large swaths of the body. When it comes to crush injuries, the first thing you want to do is do a team log roll, in which 2 or more people move the individual in sync so that they are lying on their back. If you suspect a head or neck injury, you have to immobilize it. Now, the image you see here on this slide is an example of immobilizing C-spine, or the cervical spine. Place one hand on each side of the head and do not allow the neck to move. If the neck moves, there's a chance the patient may become paralyzed. So if the patient is awake, instruct them to hold still, try not to move their head, and you have one person stabilizing their head until you can get a hold of what's called a C-collar or a cervical collar. Some of your EMTs may have one in their packs. If not, then you need to hold that stabilization until EMS arrives. If the crush injury has occurred anywhere else, you just want to minimize the movement wherever you can. Treat any bleeding that you find and seek EMS treatment. Alright, let's talk about tear gas. Now, there's a lot of names for these types of things. There's tear gas, there's pepper gas. I'm sure you've heard in the news that a lot of cops try to call it different things and claim that they're not tear gas, but essentially, as far as from a medical perspective, it's pretty much the same thing, and we're going to treat it pretty much the same way. The first step is remembering your scene safety. If you can get the victim out of there, do it, but you need to get both of you as far away from the source as possible. Don't sit there in the tear gas and try and treat it, because you're not going to get anywhere. You'll want to assist the victim in the removal of any clothing, and especially contact lenses affected. Now, I don't expect you to strip a patient naked out in the street, but if you can, try to get their shirt off if it's been suffused with the gas, because it's only going to further irritate their skin. If they're wearing contact lenses, if they at all can, try to get them to take those out, because the particles from the tear gas can get stuck in the lens and can cause damage to the eyes. This is why I would advise any of you against wearing contact lenses at protests. The next step is that we want to flush the eyes with water or saline. Be sure to pour from tear duct to edge of face, meaning you want to start from where the nose is and let the water pour out towards the outside of the face, because you want to wash things away from the tear duct. Doing it in the opposite direction is only going to wash the tear gas into the tear duct and just make it worse. Street medics generally tend to use the LAW technique, liquid antacid and water. Using a 1 to 10 mixture of antacid to water can ease the stinging, although only a more thorough cleaning at home and time are true remedies. There's not much you're going to do that's going to completely eliminate the effects of tear gas, but you can minimize it and help people feel better in the interim. If a patient is showing signs of respiratory distress as a result of being exposed to tear gas, you need to get them out as quickly as possible, and then follow basic protocols for respiratory distress. I want to thank you guys for joining us on this very brief training. We hope that it was enough of a primer to help get you reminded of things you may have forgotten. Or if you're new to this, hopefully it taught you a few things and gave you some ideas on where to look for more information. Keep an eye on our website, dallas.street-medics.org, for further trainings. And if you are part of a street medic organization and want to see your organization on our street medic map, you can use our form on that site to message us, and we'll add you to street-medics.org. Thank you so much for tuning in, and we'll see you next time.